Hello, this is Dr. Rutledge, and recently there was a comment on the MGB OAGB website. First, it was a discussion about type 1 diabetes and bariatric surgery and the treatment of type 1 diabetes, which I just did a video on. But then there was a comment which I'm going to be a little bit critical of, and so I hope the surgeon who made the comment will accept my gentle criticism, and it's made with respect and in good fun. Sometimes when I say things it sounds a little harsh, and I hope you'll accept my apologies. But there was a surgeon who said, oh, I just did a type 1 diabetic and she's doing great. I did a plication and a SADI type operation with a 2.8 meter common channel. And so I want to be critical of that, and I'm going to present some data on this. But first, I'd like to say anybody could invent any operation they want, of course. And you're seeing lots of people, they say, do this, do that, and then they publish it. Let me tell you what I did for the Mini-Gastric bypass. I started doing the Mini-Gastric bypass in 1997, and 3 years later, the first time I presented the operation, I had done 1,200 cases. Okay? You see people now, they do 10 cases, they do 3 cases. This surgeon, I don't know how many of these he's done before he recommends this. The Mini-Gastric bypass, before it was presented, I had done 1,200. Now, general surgeons can do all kinds of trauma and reconnections in the intestine and the stomach and the bowel. To me, it is extremely bad medical practice to do 1 or 10 or even 100 surgeries without follow-up and then recommend it to someone else. Bariatric surgery is filled with errors and mistakes and tragedies. And what I would say, the Mini-Gastric bypass, before its first presentation, I had done 1,200 cases. So I ask you now, 20 years later, with tens of thousands of cases, when someone comes and says, I just did the SADI in 50 people, and 10% required revision, to give it some thought. The surgeon who spoke today, tell me how many of those cases you have done. Tell me how many years of follow-up you have before you recommend this type of operation on these patients. Okay. I'm going to talk about the Mini-Gastric bypass as the best treatment for a failed sleeve, and I'm going to talk about the SADI, which is, if you don't take the plication in this surgeon's discussion, it's something like we talked about. So we're going to talk in this presentation about SADI, but we're also going to talk about a bigger topic area, which is the Mini-Gastric bypass as the best treatment for a failed sleeve. Okay, how do we decide what's the best surgery? Well, we have selection factors, which are risks and benefits, and we want safety, effectiveness, durability. I think it's critically important to have revisability, which of course any kind of sleeve is not really revisable. And we want very few complications. And we need enough cases done and enough follow-up so we can make these decisions. And again, a surgeon who comes forward and says, I just did something I invented the other day and you should do it, to me, I think that's very poor practice. So for this talk, I'm going to talk about the best treatment for diabetes. And the objectives are to, 1, talk about the sleeve failing and the choices for a failed band. You could re-sleeve them, Roux-en-Y plus a band, SADI versus MGB. So sleeves are failing, what should we do? Okay, what's the best treatment for failed sleeve? I would argue, and one of my topics here, it should be a gastric procedure plus a duodenal bypass. And we'll talk about the general surgery topics. The third topic is the Roux-en-Y is technically difficult and hard to revise. And if you add a band to that, it makes it worse. And then I'm going to talk about these distal bypasses, like the surgeon here discussed. He said, let's do a 2.8, 2.5 meter common channel. And I'm going to comment on that's really embarrassing lack of knowledge of what the outcome is likely to be for this patient over the coming 5 or 10 years of his or her life. So the SADI, which we can summarize, is kind of a sleeve plus a BPD. And we know that all sleeves are coming up with at least 30% of GERD. There have been the first publications of esophageal cancer, and it's irreversible if you do a sleeve. And the BPD is a very good operation as long as you realize it's the most dangerous of all the bariatric surgeries. It's a very long gut bypass. And we know from basic general surgery, if you resect a small portion of the bowel, less than a third or less than a half, there's almost no long-term bad sequela. But when you bypass up to 2/3 of the gut or more, then you get the risks of micronutrient deficiency, malnutrition, etc. And that's what a BPD does. And then we'll talk about the MGB and 20 years worth of data, which shows repeatedly it's one of the most effective and safest treatments, along with some tips and tricks. So we're going to look at the sleeve, we're going to look at the Roux-en-Y, we'll look at the SADI and discuss the plication version of it and the MGB. So if you have a failed band, or in this case a failed sleeve, these are the kind of things you could choose. All right, what we want to talk about now is general surgery, not bariatric surgeons who might have a interest in one versus the other, but let's just look at general surgery. And we'd like to look in particular about general surgery patients who undergo gastrectomy with either a Billroth 2 or a Billroth 1 reconnection. So what we're going to show is if you do a partial gastrectomy, that is, you decrease the amount of reservoir function of the stomach, you can reconnect the gut with either a Billroth 1, that is, the gut contents will move through the duodenum, or with the Billroth 2, in which the Billroth 2 bypasses the stream of food from the duodenum. So here's a study, gastrectomy Billroth 2, 75 gastric cancer patients with 35-month follow-up. Standard general surgery, Billroth 2, treatment of diabetes is what they evaluated, and gastrectomy with Billroth 2 showed 22% resolved and 85% improved. Okay, so let's just stop for a second and tell you something really simple. Not an MGB, but MGB type anatomy. Resect some of the stomach and bypass a little bit of the bowel. With a normal gastrectomy in Billroth 2, like the biliopancreatic limb with a Roux-en-Y, this is relatively short bypass. This alone is a very effective treatment for diabetes. Okay? This is what the MGB was based on. The MGB is more of a bypass of the stomach and more of a bypass of the biliopancreatic limb. But this basic general surgery procedure resolved diabetes in 22% and 85% improved. Now we could do more on that topic. There are dozens of other studies showing the same thing, but now let's just compare the mini-gastric bypass versus a sleeve for type 2 diabetes. This is a randomized controlled prospective trial, and basically the MGB had a 93% remission versus a sleeve which had 47%. The mini-gastric bypass patients lost more weight, lower waist circumference, lower glucose, lower hemoglobin A1C, and importantly, blood lipid levels were lower than the sleeve. I'm just going to summarize this, but every study, in all the comparisons, the Roux-en-Y, band, sleeve, and MGB, by every measure, in every study, the Roux-en-Y has the highest death rate, the highest leak rate, the highest early complications, the highest major complication, the highest bleeding rate, the highest reoperation, the highest pulmonary embolus rate, and this is true in over 100 studies. And it's certainly true that there are some very good surgeons who can do a safe Roux-en-Y, but the vast majority of studies, including the controlled prospective trials, show the Roux-en-Y is by far the most complex operation with the highest complication rate when compared to the band, the sleeve, and the MGB. So, objective 4 is comparison to the Roux-en-Y, the band, the sleeve, the MGB. The R&Y is the most technically difficult, dangerous, and we have over 100 references, but we'll just look at one. This is a learning curve study, and they said the R&Y was published technically challenging in 2,000 cases. Complications stabilized only after 500 cases. The op time complications significantly reduced after a long learning curve of 500 cases. Here's another study, and this is a controlled prospective randomized trial, 12 months, and they showed that 49% of Roux-en-Y patients versus 19% met the primary endpoints of treatment of diabetes, which really, that's great. But 37% had serious complications in the Roux-en-Y group. The two had leaks, so 3% leak rate, and one patient suffered anoxic brain injury from the infection from the leak. And patients who underwent surgery are more likely to have non-serious adverse events such as nutritional deficiencies. And only 44% of Roux-en-Ys had a hemoglobin A1C below 6. Look, the Roux-en-Y is a good operation, but it's more complicated to perform. It has more early and more late complications. This is from the first report of the American College of Surgeons, 28,000 patients, the Annals of Surgery in 2011. Compared to the sleeve gastrectomy, the Roux-en-Y had more complications, convert to open, 30-day mortality, 1-year mortality, readmission, and reoperation rate. Intubation, ventilator requirements, renal failure, urinary tract infection, wound dehiscence, septic shock, all higher in this 28,000 sample of Roux-en-Y versus sleeve. In the controlled prospective randomized trial, Roux-en-Y had more complications than the MGB, and the MGB had better weight loss. So in summary, a banded Roux-en-Y for a failed sleeve is the most technically difficult, highest complication rate when compared to the band, the sleeve, and the MGB. And adding a band adds technical difficulty. And obviously, adding technical difficulty increases the risk of complications. We know that it's a good operation, and some surgeons can do it with excellent outcomes, but the vast majority of studies document it's more difficult to do and has more complications. Plus, Roux-en-Y revision of failed sleeve has been shown to have poor complications. Plus, there's the nightmare scenario of a leak from the esophageal hiatus in the EG junction, which is avoided by the MGB. Now, what we're talking about in this particular presentation is not all the stuff I just went through, but what we want to talk about is the SADI. And so we had a surgeon here who said, do a SADI. Now, he didn't do a sleeve gastrectomy, he did application, which of course I don't know of any data on that, and I'm sure he's done 1,000 and he can tell me there are 5-year results, and I'd like to see that. But basically, here's what we know about SADI. It's a new operation, but it's based on the BPD. The idea is it includes a sleeve, and a sleeve has GERD and long-term risk of Barrett's and potentially esophageal cancer. So obviously it's not a good choice for a failed sleeve because many of those people fail because of GERD. But the second primary foundational point of the BPD is a massive small bowel bypass. And we know that that leads to malnutrition, hypoproteinemia, micronutrient and vitamin deficiencies, etc. That's why the BPD is so unpopular around the world. It's been tried, it's been around for a long time, it causes massive weight loss, which is good, but the consequences nutritionally are bad. And we know from general surgery, we're fearing the short bowel syndrome because short bowel syndrome is malnutrition, diarrhea, hypoproteinemia, and other nutrient deficiencies. And the SADI is a version of the short bowel syndrome in many or all cases at some point. So, the new operation again has two parts. One, it has a sleeve gastrectomy, which again is obstructive restriction with pylorus presentation. This creates a high pressure pouch with GERD, acid reflux, potentially for Barrett's and maybe even esophageal cancer as we get longer follow-up. It also has a common channel reported initially of 200 centimeters, which is a massive bowel bypass, and we can suggest that that's going to be much more likely to have nutrient deficiencies and a variation of the short bowel syndrome. So again, biliopancreatic diversion, sleeve gastrectomy, which is irreversible and causes GERD, and the biliopancreatic diversion, which is a massive bowel bypass, and we'll go into that in some more details in a few minutes. And the duodenal leak, if you happen to be operating in that area, is one of the most deadly gastrointestinal leaks, only equaled by a paraesophageal or EG junction leak, which the sleeve also puts you at risk for. So, from the IFSO website, the disadvantages of biliopancreatic diversion surgery: it's the most complicated, only exceeding the Roux-en-Y. Highest risk of death rate, malabsorption, even with lifelong supplementation of vitamins A, D, E, and K, B12, calcium, and iron. There's a significant risk of excess weight loss, the risk of iron deficiency anemia, and osteoporosis. The sleeve gives the risk of GERD, nausea, reflux, and added to that, diarrhea with increased stool frequency of 2 to 4 times a day, foul flatulence, and diarrhea. And recently a BPD surgeon from Europe told me he didn't want to be known anymore as the stinky, foul gas doctor and decided to switch his practice. Now, let's remember some general surgery. This is from 1935. This is general surgery, okay? Let's stop all this bariatric surgery for a minute and remember our general surgery. So I'll say that one more time because many people get lost because they forget general surgery. So we have this surgeon today saying, well, he bypassed all of this gut and he did a plication, just invented all this operation with really zero follow-up. How many cases like this has he done? So he made up this idea. In this study from Hammond, he looked at 257 patients with bowel resection. We know this. We know what we're about to show here. This is from 1935. If you resect a third or less of the small bowel, all patients had near normal bowel function. In other words, resect a small amount of bowel. No one has a problem with this. It's safe. Not perfect, but almost normal in every single patient in this study. If you bypass more than 50%, which the SADI does, dire consequences were common with particularly the short bowel syndrome. All right, let's remind everybody what we've got here. Let's imagine that the bowel length is 6 meters. Okay? The MGB can have a biliopancreatic limb length of anywhere from 150 to 200 centimeters. Okay, so let's say for argument's sake it's 1.75. That gives a common channel of 4.25 meters, so that means you bypass 30% of the gut, which from general surgery we know you can resect 30% of the proximal gut with almost no problems. Not 100%, but mostly no. Imagine with a SADI with a biliary pancreatic limb of 2.5, if you make the common channel 2.5, you bypass 60% of the gut. Okay, so this surgeon didn't mention what the amount of bypass, but 60% of the bowel has been equivalent to resected. Okay, if the biliopancreatic limb length was 8 meters, which is common, then that means that the MGB bypass is 20%, and the SADI has bypassed 70%. Okay, these patients are at significant risk, and this surgeon didn't mention the number of patients he's done and how long his follow-up is, and how many patients have suffered from severe complications. This is the same data, just shown differently. 6 meter bypass, about 30% is bypassed in an MGB versus 60% in a SADI. Or if it's a longer gut, then you're bypassing 20% in an MGB versus 70%. And we have almost 20 years of follow-up, tens of thousands of people with outcomes, and SADI has a few years of follow-up with very high, up to 10% of patients requiring revision. Okay, sleeve, 18% noted have new onset. So sleeves, trouble with sleeves. In short, Treatment of a failed sleeve with SADI is irreversible. The sleeve is a high likelihood of short and long-term GERD and possible esophageal cancer. The BPD, as described by this surgeon, is a massive bypass with risk of malnutrition, micronutrient deficiencies, foul-smelling stools, diarrhea, and flatulence. So my advice is to consider in a type 1 diabetic the MGB, and if you come up with a new operation, we're waiting to hear the results, but to just say you invented this the other day and here's the results, I think is very dangerous and borderline unethical type of practice.